I want to say that 40 to 50% of lesions in the femoropopliteal area and below the knee constitute a CTO. So it is obligatory for a peripheral interventionalist to be competent with treating CTOs, and that is why we are discussing these today. Because many of my colleagues have given their personal perspectives, I have tried to keep my personal perspectives completely out of my presentation and completely rely on what the data suggests. And the outline of this talk that I've tried to frame is that when to opt for the Guidewire versus a CTO catheter, if we could determine this from the data we have collected. And second is, does it actually matter? And I want to start off with a very quick raise of hands from my panels that if you see this lesion with a little collateral, Erin, starting with you, would you choose a Wire-Catheter or a CTO approach as your first go? And you can just say, and we can take a quick rapid fire here.
I would go Wire-Catheter.
John, I know your answer.
Agree.
Wire-Catheter.
Ditto.
Same here.
Yep.
Manas always agrees with me, so
I will defer to
so we decide how we go. So what we did was that, one thing I want to point out, which is I hopefully has come through what our speakers before me have said, is that a crossing strategy is not just a crossing strategy. At least in the periphery, it does impact what happens subsequently in terms of use of atherectomy and overall treatment. In coronary, the DES is the end result of most intervention, but not so much in the periphery. So I think defining the lesion and paying attention to the crossing strategy and how it would impact on subsequent treatment approaches is something to consider. So what I want to present is not my work, but the work of many of individuals and highly skilled interventionalists who participate in the XLPD registry who are here in this room and on this panel. And what we were able to discern from nearly 3,000 cases we have accomplished to compile in the XLPD registry, that three factors very reproducibly determine the course of our approach for femoropopliteal CTOs. The three things are tapered proximal cap, a tapered proximal cap in addition with involvement of the P2 or P3 segment of the popliteal artery, and that is an indicator for involvement of below the knee vessels. And the third is the same features plus, and in addition, an ambiguous cap. So what we did is classify this into three categories. Type A, based upon lesion length, 50, 50 to 100, and greater than 100. This schematic was first proposed by Jihad, and we have confirmed this in our own observation. If you can see, most of these lesions, at least in the registry, are attempted and initially crossed and treated with a Wire-Catheter approach, and it is lesion types 3B, 3C, and 2C with a longer and more ambiguous cap with a retrograde approach, combined with use of crossing devices which are previously attempted before a retrograde approach or a hybrid approach is adopted. So in the other is that this is one way, at least what we have seen in our experience, and I want to take you down through this slide, that if you consider both above the knee and below the knee infrainguinal CTOs, the first point I want to make is that there is still a significant number of 035 wire-based technologies used to cross lesions. I have put a downward arrow in front of it is because we see a clear trend of the use of 035 system reducing. As you can see, that many of the crossing devices and re-entry devices are 014 systems. A traditional approach would be to use a Treasure 12 and Confianza Pro and then escalate. This is a wire escalation strategy. And in below the knee, a soft wire like a regalia has been most commonly used in the registry. Now, we also heard some of our speakers before me indicate some features where they would prefer one approach over another. And on this slide, to your left, are three features that have prompted the use of an antegrade approach, mainly in lesions with a tapered cap, mostly in claudicants, and with CTO lengths greater or equal to 100 millimeters. If you see the darker lines, most commonly what we see in the registry for these types of lesions, that are lesion 1A, 2A, 2B, and 3A, is using an antegrade Wire-Catheter approach, and if you don't enter the true lumen, use a dissection re-entry and re-enter with a re-entry device. For a retrograde approach, you will also see that the presence of an ambiguous cap, what I called is an ISR with a hostile SFA, that is a combination of long ISR lesions with stent fractures, presence of below-the-knee disease, appropriate distal access target, and mostly in CLI where a retrograde approach is used. And you can also see the bold lines where a retrograde approach is primarily use of a wire catheter. One other thing I observed in the registry, which is important to point out, is a unidirectional arrow between crossing devices and wire catheter. That means that if what it tells me is what Sahil before me said, that if the wire makes a bigger loop and you have a 4 or 5 millimeter loop in the subintimal plane, I think you are toast at that point and you have to either re-enter. So there is no way of using wire catheter failure, creating a big dissection loop and then coming back with a CTO crossing device. It only goes in one direction. So these are some pointers which I think will help us collect this data and move forward. Now, let me move forward here. I think my slides are going in the other direction. I also want to emphasize that while we consider these approaches, we should consider and educate ourselves on the constructs of many of these guide wires. And I, of course, cannot go through each one of them in great detail, but here is an example where we should pay attention to the tip load, to any kinds of angulations or microtips. A presence of a composite core in a wire increases its durability and torqueability, and I kind of classify the qualities of a wire across these 4 points, that is support, torque, penetration, and lubricity. And I think if you should pay attention and select a few wires that you think would be appropriate for your lab. There is a host of crossing and support catheters because it is imperative that these guide wires are advanced over a support catheter. The one we use frequently in our labs is the CXI. There's a host of crossing devices, and I'm not going to belabor this, but a point I want to make here is that in the registry, we are currently seeing an increase in the number of crossing devices, a little bit contrary to what Jeff just said. We used the data published in 2015 suggested a 15 to 18% use of crossing devices. Now we see about 29 to 30%. And I can tell you my gestalt why this is so. How, on one direction, we can't really teach our fellows and colleagues how to handle the wire loop, but using a crossing device gives us a reproducible and a teachable moment how to use those devices. So if you can master one, I think that would be very essential. And we see the low-profile Viance to be making a greater headway among other crossing devices. If you can see on the angio, very subtle movement of the Guidewire tip allows you to deflect the crossing device and engage the lesion in a different way and then successfully cross into the true lumen. There are a host of publications. While I have no intentions of taking you through down all of these studies, but I do think that XLPAD classifies crossing strategies very, very strictly. We separate between primary technical failure and primary technical success. And primary technical success means that the initial crossing strategy actually makes it to the true lumen. We also separate between secondary crossing and provisional crossing based upon alternate approaches that we have been discussing. And here is a case. The middle panel after the ostial SFA is actually true. There is no vessel and just hazy, very little filling of the anterior tibial. We use a retrograde approach to cross, use a quick cross catheter, and after balloon dilation through an antegrade approach, we're able to direct the wire into the sheath of the antegrade catheter, into the catheter, and then externalize. And I use, in this case, a treasure floppy escalated to a treasure 12 and then a SFACTO. And we define, based upon the XLPAD classification, that this is a type 2C lesion because it reconstitutes below the P2. It's a tapered cap and the length greater than 100 millimeters. Now, this is a different iteration of the slide that Dr. Burkett mentioned. As you can see, when this publication was made in 2015, only 18% of crossing device was used versus a majority. We also saw that these crossing devices are used in mainly more advanced lesions, so there's a greater degree of subintimal crossing and greater degree of stent use. Technical success, where the initial device or wire crossed into the true lumen, was higher with the crossing device. However, procedural success means that the operator was able to complete the procedure with a less than 30% residual, were equivalent in both these groups. I did not show you the 30-day outcomes, however, which were equivalent. At 1 year, the need for repeat endovascular and surgical revascularization, at least in the CTO device group, was statistically significantly lower. And I was kind of perplexed. Why is this so? Here is a comparison of all the features between the Wire-Catheter and CTO Crossing device, and what I think is Mark indicated, that we definitely saw a larger use of stent, which I think could have indicated to the greater durability in the intermediate term. I think this could be completely flipped if we followed the patients longer, and there could be more restenosis, but that is the data as it currently stands. Because a procedural success was achieved equivalent terms in both the arms, there was a consistent improvement in Rutherford category and improvement in patient symptoms and ABIs, irrespective of which strategy was chosen. So as long as we get proficient with one, we can do a good job. The cost issue has been mentioned. As you can see, the crossing devices have higher cost. And we also went ahead and calculated in this paper something called the incremental cost effectiveness ratio, that if you at 1 year prevent some need for repeat revascularization, but do incur the additional initial cost of a CTO crossing device, the incremental cost effectiveness ratio stands at $423.80 for using a crossing device per procedure. Of course, these are 2015 data. This is an unpublished data which is going to be submitted to abstract to ACC, as that we definitely see, at least in the femoropopliteal area, an increase in CTO crossing devices up to now to 29%, which again goes against the logic of cost. The other thing we notice that amongst all the current devices, the 014 Viance and Frontrunner, Viance actually exceeds the pack, at least how it stands currently in the XLPAD registry. To conclude, I believe that careful lesion assessment using a standardized classification is very useful to create and develop a consistent reproducible approach with either Wire-Catheter or crossing devices. I also believe, based on the observations made by my colleagues and us having compiled them, that proximal cap morphology, lesion length, and involvement of proximal popliteal and below the knee vessels are key drivers of crossing strategy. What you see amiss here is the absence of calcification, because I do believe there are no good calcification solutions. Finally, although crossing devices in one single study from our group demonstrate higher technical success, I do want to reiterate that we can achieve comparable procedural success and comparable improvement in patient outcomes with either strategy. Thank you very much.